Myringotomy or Tympanostomy by P.L. Dhingra, Chapter 78. Myringotomy is the insertion of the tympanic membrane with the purpose to drain suppurative or non suppurative effusion of the middle ear or to provide aeration in case of malfunctioning Insertion tube. Ventilation tube, Grommet, may be required in the latter case. Indications 1. Acute suppurative otitis media. Severe ear ache with bulging tympanic membrane. B. Incomplete resolution with opaque eardrum and persistent conductive hearing loss. C. Complications of acute otitis media. Example facial paralysis, labyrinthitis, or meningitis with bulging tympanic membrane. D. Recurrent acute otitis media. 2. Otitis media with effusion. 3. Aerotitis media to drain fluid and unlock the Insertion tube. 4. Atelectatic ear. Grommet is often inserted for long term aeration. 5. Intratympanic injections. When several intratympanic steroid injections are to be used for sudden sensorineural hearing loss. Anesthesia. In infants and children, always use general anesthesia. For adults, general anesthesia is used only when tympanic membrane is acutely inflamed. If there is no inflammation, myringotomy can be done under local anesthesia or no anesthesia at all. Steps of operation 1. Ear canal is cleaned of wax and debris. 2. Operation is ideally performed under operating microscope using a sharp myringotome or a good suction apparatus. 3. In acute suppurative otitis media, a circumferential incision is made in the posterior inferior quadrant of the tympanic membrane, midway between the handle of malleus and tympanic annulus, avoiding injury to incudo-stapedial joint. 4. In otitis media with effusion, a small radial incision is made in the posterior inferior or anterior inferior quadrant and all the effusion is sucked out. When the ventilation tube is to be inserted, incision should be just enough to admit the tube and is preferably placed in the anterior superior quadrant for long retention. Pitfalls of myringotomy 1. When tympanic membrane is thick, incision may remain only in the superficial layers of eardrum head without cutting through its entire thickness. 2. Incision in the posterior meatal wall. This may happen when distinction between eardrum head and posterior meatal wall is lost, when both are inflamed. 3. Beware of vascular anomalies of the middle ear, such as high jugular bulb, aberrant carotid artery, or glomus tympanicum. Postoperative care. Daily mopping of ear discharge will be required in cases of acute suppurative otitis media. In serous otitis media, just leave a wad of cotton wool for 24 to 48 hours. Drum incisions usually heal rapidly. No water should be permitted to enter the ear canal for at least 1 week, and if a grommet has been inserted, entry of water is prevented so as long as grommet is in position. Complications 1. Injury to incudostapidial joint or stapes. 2. Injury to jugular bulb with profuse bleeding. If jugular bulb is high and bony floor of the middle ear is dehiscent. 3. Middle ear infection. Figure 78.1 A. Circumferential incision used in acute suppurative otitis media. B. Radial incision used in serous otitis media. Figure 78.2 Grommet in right tympanic membrane. Grommet. It is a ventilation tube placed in the tympanic membrane for drainage or ventilation of middle ear. It has also been called pressure equalizing or tympanostomy tube and is made of Teflon or medical grade silicone which are biocompatible. Some grommets are made of gold or titanium. Complications of ventilation tube include A. Blockage due to blood or secretions, B. Middle ear infection, C. Extrusion, D. Persistent perforation after extrusion or removal, E. Granuloma formation, F. Tympanosclerosis. For long term ventilation or when grommets are repeatedly extruded, a T tube can be used. Thank you.